Good evening and welcome back to Teach Me Tuesday. I'm back in St. Louis, not in Nana anymore, recovered. Had to kind of catch up on my work, and here we are back with another Teach Me Tuesday. Today we are going to talk about the golden hour and kind of what that means and how we can best prioritize and help our babies during that first hour of their life. So let's review. So I love kind of trying to figure out where these things come from. And what I love about the golden hour is that this was first talked about in trauma centers and like, how do we get those trauma patients in and stabilize them and get them to where they need to be within that first hour? But the goals of trauma and the goals of NICU in the first hour are a little bit different. So what we are really focusing on is, those big ones that we talk about: thermal regulation, respiratory stability, IVH risk reduction with fluid balance and neuroprotective care, cardiac stability, sepsis prevention, and of course, parent support. So the thing I want you to jump to on the screen right away is that statement there. So we're talking about thermal regulation, right? With thermoregulation, when we say, we want the baby to have a stable temperature, but to look at the statistic of for every degree the baby goes below 36, their mortality increases by 28%. That's a big deal. That is a lot. So we don't want them to just okay, let's keep you nice and warm. It's let's keep you warm from the minute you come out. So our goals are to use a polyurethane cover, such as a poncho or just that clear plastic on top. Back in the day, for those of you that maybe have been working as a NICU nurse for a while, we used to use saran wrap, right? We would do whatever we could to kind of protect the baby and also prevent transdermal water loss. We don't want any swings in the temperature. We don't want to overheat the baby and then have to have the baby cool down. We don't want the baby getting very cold. Both of those can be dangerous to the baby. We want to prevent hypothermia at all cost. So tips for practice, things that we can do within the delivery room or in the NICU, is to use that plastic cover in the NICU room, in the delivery room, and in the NICU. One thing that I think is really important is if your baby is starting to get cold, you can bring that polyurethane cover back. I think that's a missed thing or something we just don't think about. Sometimes we think of the poncho or the cover as a delivery room tip and trick, like a mechanism we use in the delivery room, but really we can use that in the NICU. We can use it in an incubator. We can do whatever we need to help keep that baby warm. Having your delivery rooms ahead of time, nice and warm, anytime you have the opportunity, right? We all know that we have crash C-sections or precipitous deliveries that we can't anticipate, but anytime we can, getting that baby's room warmed up and ready for them. If you have incubators such as giraffes where the top opens up, or the dragers, baby Leos where the top opens up, is getting that closed as soon as possible after placement of lines and x-rays and labs, whatever you might be doing. Getting humidity in place by 1 hour of life. We also have those warming mattresses, which are basically just giant heel warmers that the baby can use. They're good for about an hour. There are some drawbacks to them. Most of them cannot be x-rayed through. So just thinking about what that means for the baby. And then, of course, just using, positioning changes, get the temperature probe in a good place, use of humidity and all of those devices as soon as possible during that first hour. So now let's talk about respiratory. So we want to have effective ventilation. That's our goal. But one thing with effective ventilation is we have to be mindful that we're not over ventilating the baby. Overinflation leads to BPD and PIE, and we just don't want to have these situations where we're over-ventilating the baby. So using x-rays to help us know what's going on there, and of course our blood gases. Having our oxygenation at good levels with low amounts of oxygen requirements. So keeping them in that, tight control of being around 90 to 95. Having a good pH balance, so making sure that we're using ventilation and other tactics to correct that. We don't use a ton of sodium bicarb anymore, but we might need to, or we might need to get a TPN change earlier than needed to get that pH in a good place. Effective use of non-invasive mechanical ventilation. So not only is CPAP helpful, but NIMV or NIVNAVA, any of those non-invasive ventilation systems that you may be using is going to be super helpful in these scenarios. And anytime you're using that, we also want to make sure we have a gastric tube down for decompression. If you think about what the belly's doing, and if it gets full of air, it's just going to push up, and it's going to push especially on that left lung where it cannot fully expand. It's also going to make the heart compressed, so we want to make sure that we're decompressing that belly whenever we can. So tips for practice, really thinking about right when that baby gets down, getting that NG or OG in prior to the x-ray so you know if it's in a good place, getting your TCOM in place before the first blood gas is sent so that if they are reliable, we can work on that off of the TCOM. Limiting the use of suction. You know, we have this thing where if the baby's having a desaturation episode that we want to suction, but really limiting to it. If you can see it, then you should suction it. And if you can, you should go ahead and get in there, but too much suctioning is just going to inflame the baby's airway. And then remember to treat oxygen like a drug and to wean it whenever you can. So if we think about fluid balance to reduce our risk of IVH. So our goals for this is to have that quick placement of central line. So anytime you have those small babies, if we can get a central line in, whether that's a UV or UA or both, it's going to really, really enhance our abilities to have fluid balance and to reduce painful procedures that also are going to increase our risk of IVH. Start with total fluids around 100 mils per kilo per day seems like a great amount until your baby weighs 400 grams and maybe you have 2 lines and you can't even keep the 2 lines open with the rates that you're running at. So being mindful of that, but aware of, where if we're giving boluses after medications, if we're getting flushes, all of those little things are adding up and contributing to your baby's total volume intake. Monitoring our blood pressure, watching our urine output, starting with some sort of starter TPN, something that has protein in it and is not just a sugar substance, and then watching our electrolytes. So in practice, some places get an IV in before they even start a central line. Some places don't put it in unless they can't get a central line. And then some are in the middle where, hey, maybe it's been 30 minutes, let's stop and get that PIV in. It's going to be helpful to have identified an area where maybe you could start an IV, know who your most experienced or best IV poker is, but if you're going to run into these scenarios. Advocate starting for fluids prior to x-ray. Just like as if it's a low-lying UVC in an emergency, it's probably in a safe enough place that we can get some fluids going. Urine output is a missed vital sign. It's something that we don't always look at to really tell us what's going on with our babies, and really watching for any changes in your urine output. And then get those electrolyte lab draws whenever you're doing your blood gas, or if you can run electrolytes on your blood gas machines, that's going to really help keep a close eye on what's going on with your baby. Cardiac, our old friend, the blood pressure, right? So we want to have close blood pressure management. In our small babies, hopefully we have a UAC in, or in our sick babies, or if we're doing any sort of cuff pressures. It's important to know that MAP is not our only indicator of poor blood pressure. And in fact, our MAP could be lower than our gestational age, which is what we always compare it to. But if the baby has a great urine output, if they have a great capillary refill, if they're active, it might not be actually symptomatic. So we need to look at all of those things. Once we've given a bolus in small babies, we may only give one bolus before we start pressures because we don't want to fluid overload them. So thinking of what would be the next pressor we would use. Watching your heart rate, and again, we're coming back to that urine output. Knowing what is going on with our urine output. Once you've given, and your tips for practice, once you've given a bolus, maybe getting that first blood pressure medication to the bedside. Looking at your peripheral and central blood pressures. Once they're correlating, really taking that blood pressure cuff off so that we are protecting our baby's skin integrity. Doing that frequent assessment, watching our perfusion, watching our urine output, not really letting them go more than 4 hours before looking at us, testing our fontanelle, seeing what's going on with the baby. Sepsis, my old friend. We want to get that blood culture and CBC immediately on admission. That should be an immediate goal. Get our antibiotics going if they are ordered, really thinking about those risk factors. What was the baby exposed to that puts them at risk for sepsis? So length of rupture, maternal temperature, type of delivery, all of those things, traumatic delivery, where was the baby delivered, are going to factor into if your baby needs antibiotics. And the goal should be to have the antibiotics started within 1 hour of the order being placed. Check into your facility, find out what does a stat order mean? How quickly can we get those antibiotics up to the NICU? So tips for practice would be getting labs from your line insertion. So as soon as the line goes in, drawing your blood culture and your CBC. Consider your antibiotic orders, right? We want to have those broad spectrums like AMP and GENT, and then giving them in order that it makes sense to you. We usually say, let's give the one that runs over the shortest time first. So AMP versus GENT, we're going to run AMP because you can run it in and then your flush, and then get your GENT going all within that first hour. Make sure the medications are ordered stat and have a Medline ready to go when those medications get there. Those are all going to help reduce your baby's risk of sepsis. So parent support. Our goal is to always bring a second parent, a support person, another person down to the NICU to see where the baby's going to go on admission, to start teaching them touch hold, to show them stress signs, to orient them to the NICU. We must remember that any admission to the NICU is a traumatic event. So we're going to need to have a lot of repetition in our education. So showing them the monitors, telling them about the medications the baby's going to be on. What does care time look with? When are diaper changes going to happen? How soon can we get this baby out for kangaroo care? All of those are going to be so important to helping this parent become the primary caregiver for the baby. So we've passed our golden hour, right? And the really important thing to remember too is that we're not rushing, we're just prioritizing our care. So during those next hours afterwards, we really need to continue to think about thermal regulation. Is our skin temp probe in a safe place where it's giving us an accurate reading? What is our blood sugar? Ideally, we're going to keep that blood sugar between 60 and 120, but we really want to watch for those fluctuations. We don't want our blood sugar to be going up and down. Watching our blood pressure, not just for changes, but also our cap refill, our fontanelles, our activity, our urine output, all of those things are going to factor into that blood pressure management. And then your small baby or neuroprotective care guidelines. So no leg lifts, so no more of that lifting the butt up to get the diaper changed underneath, slow progressive position changes, so kind of the log roll, keeping the baby's head midline whenever possible. No baths or wait in those first 96 hours or for however long your unit does midline care. Oral care and feedings within those first 24 hours, that's going to be a huge priority for the baby. And defer any sort of other PICC line placement as long as you can after those first 72 hours. So to recap, this is a critical time period for the baby, but it's not a time for rushing. We're not saying like get in there and do as fast as you can, but it's prioritizing our care. What can we do before the baby even gets there? Can we have, some pended orders so we can get our fluids to the bedside and get our fluids strung through our IV tubing so it's ready to go? Can we have someone prepared to put in the central line? Can we have a warming mattress ready to go, an incubator with humidity ready to go for the baby? Focus on going system by system, knowing what your goals are, and knowing that having the parents there should be key to this time. This is a very important part of what's going on for the baby and the family unit. So thank you for coming and listening all about the golden hour. Comment below with any questions or anything else you'd love to see. Have a great night.